The examination of the shoulder joint. The first step in examination of any joint in the body will involve exposing the patient adequately. For the shoulder joint, you will need to expose the patient by removing their entire top. In a male, and in a female, you will obviously leave the undergarments on. The general examination of all patients follows a certain standard format. In orthopedic surgery, all patients in clinical examination, you stand the patient first, except for the hand examination. But there's no other clinical examination other than hand examination where the patient does not need to stand first. The shoulder is no different. Other things that you need to take into consideration generally when you examine a patient are the joint above and the joint below. The reason being referred pain. Pain in one joint can be referred to the second joint and thereby mimic the pathology in that joint. So for the shoulder, always consider the neck and also consider the elbow. In addition to that, always consider a neurovascular examination. The reason being nerve pathology and muscle pathology, nerve pathology and vascular pathology can mimic musculoskeletal pathology. Thereby, shoulder pain can be mimicked by brachial plexus injuries or brachial plexus compression or cervical nerve compression or any vascular problems up and around the neck. In any clinical examination in orthopedics, the best way to approach your clinical examination is to learn the steps or to be able to rehearse the steps before you actually do them. The shoulder examination is no different. We will start it by doing look, feel, move. Therefore, to rehearse the steps of a shoulder examination are as follows. Stand the patient, look, feel, move. Examine the rotator cuff and muscles around the shoulder girdle in its entirety, followed by impingement tests, followed by instability tests. Therefore, the system is look, feel, move, rotator cuff and muscles, impingement, instability. And we will examine the patient in that particular order. The first thing we do is we stand our patient and we look to see the way the patient stands. We look at the attitude of the upper limbs and we look into their face to see if there is any pain. It's good at this time to do a quick screen of the neck, as I said, joint above, and ask the patient to actually move their neck from forwards and then backwards, one side and to the other side, and to ask them, does that movement simulate the shoulder pain that you get? So it's good as a first screening tool for your patient. In particular, when you're looking, you are looking for areas where there are any scars or any muscle wasting or any obvious deformity. Remember to look into the axilla, because many surgical approaches could be through the axilla and you will miss those. So inspection is not complete until you look into the axilla for any signs of any scars. Look for areas of wasting, and remember your anatomy when you are actually looking at wasting. For example, this will be the deltoid area and you are looking for wasting around the deltoid area. Look at the pectoralis major, and at the back especially for rotator cuff injuries, you look at the area of the supraspinatus muscle and the area of the infraspinatus muscle for areas of wasting, especially in rotator cuff tears. Next comes palpation. So the shoulder joint is a deep joint, and therefore you don't gain very much from the shoulder joint per se from palpation because it is very deep. However, you need to complete your examination by palpating. Palpation starts in the shoulder girdle around the sternoclavicular joint. Always remember to look at the patient's face, where you palpate the bony structure of the clavicle, around the acromioclavicular joint, the tip of the coracoid, the biceps tendon, and along the back, the spine of the scapula, feeling for any areas of tenderness. Movements of the shoulder are best done when you actually demonstrate to the patient how to go about doing the movements, because many patients will not be able to understand what you say. Therefore, it's a good method to try and demonstrate to them and do it along with them while they're doing it. Therefore, we will do flexion, forward flexion. Extension is very rarely done for the shoulder. We will do abduction, internal rotation, and external rotation of the shoulder joint. For forward flexion, you follow me and we see how far we can go above as high up as you can get. You quantify that in terms of degrees. For abduction, we'll do it first looking at the patient, where you raise your arms above as high up as you can get, and then down. And then either go behind the patient or ask the patient to turn around and repeat that examination where you ask them to abduct as far up as they will get. Because shoulder abduction is a combination of glenohumeral and scapulothoracic movement. The first 90 degrees or so is glenohumeral, and the second 90 degrees is scapulothoracic. So that particular movement is a combined glenohumeral and scapulothoracic movement. There are ways of separating them, but we will not go through that during this examination today. Turn back. For internal and external rotation, we ask the patient to put your elbows into the side of your chest, and then you bring them out as far as they go for external rotation. And because the tummy is in the way, you can't do internal rotation that way. So you ask them, if you turn around for me, you ask them to reach up as far as they can get, and they should be able to get to the mid-thoracic spine with good internal rotation. After you've done the movements, then you need to look at the three main pathologies of the shoulder separately. It is best to separate rotator cuff examination from impingement tests, followed by instability tests. When you examine patients and look at the shoulder girdle, you will see wasting around the shoulder girdle. Most of the time that is related to rotator cuff tears. However, in certain instances, the muscle wasting is not rotator cuff, but the other muscles of the shoulder girdle. So a complete examination will include the other muscles of the shoulder girdle. I will demonstrate those separately at the end after we've completed the full examination. To assess the muscles of the rotator cuff, you have to remember that there are four muscles of the rotator cuff. They are supraspinatus, infraspinatus, teres minor, and subscapularis. We will test each of them separately. However, infraspinatus and teres minor are both external rotators of the shoulder and can be tested together. For supraspinatus, what you need to do, remember shoulder abduction is the action of deltoid and supraspinatus. So you have to take deltoid out of the equation. To do that, you put the shoulder or the arm in the direction of the supraspinatus fibers. Therefore, this is the coronal plane, 30 degrees forward in the coronal plane, and 60 degrees of abduction is at the point where the fibers of supraspinatus are in a straight line. And by internally rotating the shoulder, I have taken the deltoid out of the equation by slackening the deltoid. Therefore, when I ask the patient to resist my movement, it is purely supraspinatus I'm testing. To test combined infraspinatus and teres minor, which are external rotators of the shoulder, we ask the patient to put their elbows back into your chest and externally rotate against resistance. And by doing that, and if we turn around, and by doing that, I can feel infraspinatus here resisting me. Now there is a way of separating infraspinatus and teres minor, and that's called Hornbrough sign. Now, if you abduct the shoulder to 90 degrees and ask the patient to externally rotate the shoulder, then at this point, infraspinatus is mainly teres minor working. Therefore, if you ask the patient to externally rotate the shoulder at this point, teres minor is not working. In the effort to try and externally rotate, this hand drops towards the mouth like that. And that is blowing like blowing a horn. It's called Hornbrough sign. The fourth muscle to test in the rotator cuff is subscapularis. To test subscapularis, remember subscapularis is an internal rotator. The most common test used is called Gerber's lift-off test. Therefore, you ask the patient to put their hand behind their back and push away from me, and to test the power of subscapularis. So Gerber's lift-off test is the most common way of doing it. You can also do the lag sign, where you ask the patient to keep it up like that and keep it there. And with a weak subscapularis, it will fall into the back. Some patients, however, are not able to put their hand behind their back, and the other test you do is called the belly press test or Napoleon sign. In other words, you ask them to press into their belly like that, and if they can normally keep their elbows out like that. But if their subscapularis is weak, this elbow will drop backwards. That's called the belly press test or Napoleon's test. Napoleon Bonaparte. Those are the four muscles of the rotator cuff that we tested. Firstly, supraspinatus, followed by infraspinatus and teres minor, which can be tested together, and fourthly, subscapularis. After testing the rotator cuff muscles, we do the impingement tests. I'll describe four of the more common impingement tests that we examine for. Remember, some patients present to you with pain in the shoulder, especially in the middle-aged patients, and they have impingement. Impingement means there's something catching within the shoulder, within the area of the shoulder girdle, usually in the infraclavicular region. Most commonly, things like small rotator cuff tears will be causing impingement, and these patients present with some pain. The four impingement tests I'll describe are Speed's test for biceps tendonitis, the scarf test for acromioclavicular joint pain, and for subacromial impingement, you can do one or two of these tests: Neer's sign and Hawkins test. Okay, so the first one is Speed's test. And Speed's test for biceps tendonitis is like if you're doing 10-pin bowling. So you ask the patient to do as they're going to bowl a ball in 10-pin bowling, and you try to resist it. So ready to do that for me? Pull backwards, yeah, and then go forwards. Now the patients with biceps tendonitis, in doing that and me resisting, when they try to bowl the ball like that, will have pain in this area. For scarf test, which is for AC joint pathology, you bring the arm like a scarf across the neck. So like a scarf across the neck, push in like that, they will get pain here over the AC joint. The common one, however, is the test for subacromial impingement. The classical one is called Neer's sign. Now, Neer's sign is where you internally rotate the shoulder, and you passively, that means you do it yourself, abduct all the way
and see how normally a patient can get to at least 130 degrees. If a patient cannot get by doing that to 130 degrees, it's a positive Nair's sign for subacromial impingement. There is something called Nair's test, where you give a subacromial injection, and by giving that injection into the subacromial space, and the patient allowing you to abduct beyond 130 degrees, will indicate it's a positive Nair's test. Hawkins test is one where you abduct the shoulder and internally rotate in various points and see if that brings about pain. That's called Hawkins test. The final group of tests you do after doing impingement tests are instability tests. Remember, instability tests usually result in apprehension of the patient after that, so you tend to keep the instability testing for last. The tests that I'm going to describe are firstly looking for the sulcus sign for multidirectional instability, looking for anterior instability via the anterior apprehension test, looking for posterior instability via the posterior apprehension test, and there's something called the load and shift test where you look for anterior and posterior translation of the joint. For the sulcus sign, especially in patients who have generalized ligamentous laxity, you pull down on the shoulder and look for a sulcus in this area, which shows you that there is a big dimple here when you pull down, indicating this patient has multidirectional instability. And we look into this area just below the acromion here. For the load and shift test, it's like an anterior and posterior draw test in the knee. So you hold on to the scapula of the girdle here, you hold on to the humeral head, and you translate it forwards and backwards, and you see if there's any instability in doing that. That's called the load and shift test. For anterior apprehension and posterior apprehension are mainly done in the patient who's lying on a couch. However, in most situations, you don't have a couch available, and you can do it also sitting down or standing up. You go into this position like if you're throwing a javelin, and you ask the patient to abduct and externally rotate the shoulder. The patient with anterior apprehension usually does not want to do that. They look nervous when you start doing that movement. There's something called you can also press down on the front of it, called the relocation test, and they feel a bit better. For posterior instability, you do the posterior apprehension test, which is really this movement where you adduct the shoulder, and you push and you forward flex it slightly, and you just simply push backwards, and then look in the patient's face again to see if there's any apprehension. Before we complete the examination, where I said you always remember the joint above and the joint below and neurovascular testing, I'd like to demonstrate to you other muscles of the shoulder girdle. Remember, when you look at a patient and they have shoulder pathology, they can have significant wasting of the shoulder around the shoulder girdle, and you're not sure whether this is the rotator cuff. It could be other muscles around the shoulder girdle. So I'll demonstrate to you in particular these muscles: the pectoralis major, latissimus dorsi, the deltoid, the trapezius, the rhomboids, and the serratus anterior. From the front, to examine the deltoids, you can just simply abduct the shoulder and ask the patient to resist it, and you feel the deltoid contracting. Remember, don't bring it forward because supraspinatus will come into action if you do that. If you simply just abduct it in this position, ask them to resist, that's the deltoid that you're testing. To test for pectoralis major, you ask the patient to hold their waist and push in, and then you feel your pectoralis. You feel your pectoralis major as you push in. Ready? Push in. To test for latissimus dorsi, it's like climbing the ladder. Ask the patient to rest their arm on your shoulder and simply press down, and then you feel the latissimus dorsi at the back here. To test for trapezius, you ask them to shrug the shoulders up and resist me, and you push down, and you can feel trapezius here. To test for rhomboids, you ask them to bring their shoulders backwards like that, resist me, and you can feel the rhomboids here. The last test is for serratus anterior, for which weakness of serratus anterior can cause winging of the scapula, is to ask the patient to push against the wall, elbows extended, and palms of their hands pointing downwards like this. So just like this, you push in and press against the wall, looking for any winging of the scapula. As I said before, to complete your examination, you will not always be doing these muscles. This is only in cases where you have significant wasting around the shoulder girdle and want to see if there are any other muscles other than the rotator cuff muscles that are torn. To complete your examination, you always remember the joint above, that is the spine, joint below, that is the elbow, and neurovascular examination of that limb. To summarize, we will run through the whole technique from beginning to end. So we'll stand our patient, we will look, we will feel, we will move, we'll do a rotator cuff examination, test for impingement, and finally instability tests. Always remembering that we have to consider joint above, joint below, and neurovascular observations. So stand our patient and looking from the front. Do you mind moving your neck from forwards, backwards, to one side, on the other side, and does that simulate your shoulder pain? Looking from the front for any wasting, any scars, looking from the side, wasting scars, and looking at the back for any wasting scars. Always remember to look into the axilla. Palpation starts at the sternoclavicular joint, moving across the clavicle to the acromioclavicular joint. Feel for the tip of the coracoid and the biceps tendon. You also continue palpation along the scapular spine. Movements are firstly forward flexion, as high up as you can get, and bring it down. Abduction from the front, all the way up, bring it down. Turn the patient around and abduct again, as high up as you can get, bring it down. Turn back around, elbows into your side for external rotation, and for internal rotation you ask the patient to get as far up the back as they can get. In terms of testing the rotator cuff, firstly supraspinatus, 30 degrees up from the coronal plane, internally rotate the shoulder and resist me. Supraspinatus. For combined infraspinatus and teres minor, ask the patient to externally rotate, feeling for the infraspinatus muscle. If you want to separate the teres minor and the infraspinatus, you ask them to abduct the shoulder to 90 degrees and externally rotate in this position. If they can't do that, then the arm falls in towards the mouth. That's called Hornblower's sign. For subscapularis, you ask them to do either one of three things. You ask them to do the Gerber's lift-off test by pushing away in an internally rotated position. There's the lag sign where you ask them to keep their turn around. The lag sign where you ask them to keep their arm up over their back. And then for those who can't internally rotate, you do the belly press test or Napoleon sign. For the impingements, we're going to do Speed's test for biceps tendonitis, as though he's doing 10-pin bowling, and he feels pain here. For the AC joint pathology, we do Scar's test. For the subacromial impingement, we will do Neer's sign, which is 130 degrees at least of abduction and forward flexion, or Hawkins test. And finally, for instability, we do for the sulcus sign, we do the anterior posterior drawer load and shift test, the anterior apprehension, and the posterior apprehension test. As I said before, if there's wasting, we can look for it and test the other muscles of the shoulder girdle. But always remember, joint above, joint below, neurovascular observation.